We have Mr. Anwar, who is a 55-year-old male patient, and he has no past medical history, and he presented with abdominal pain for which an ultrasound showed a liver lesion. He also had an MRI and would like to ask our radiologist to review the image.
Yes, indeed. The MRI confirmed a 4 centimeter right lobe mass in the liver that shows subtle hyperintensity on T2 weighted and enhancement on arterial phase image. There are also 2 small lesions in the left lobe, 2 and 1.5 centimeters in diameter. The rest of the liver looks of normal structure with no evidence of cirrhosis. Have you done AFP at all?
Yes, it was done and it was elevated. Alpha-fetoprotein was 670. His CAA also was elevated at 140. The patient is keen to start treatment as soon as possible. Let's see what we can do today.
Liver biopsy to confirm HCC is not always indicated, except in some circumstances, such as if the CT or MRI results do not meet the imaging criteria of HCC, in patients who are not deemed high risk for HCC, such as those with no cirrhosis or history of previous HCC, in patients with conditions associated with formation of non-malignant nodules, such as cardiac cirrhosis and congenital hepatic fibrosis, and finally, biopsy indicated in patients with high CA99 or CAA to rule out intrahepatic cholangiocarcinoma or mixed HCC cholangiocarcinoma. I think we really should send this patient for a biopsy because we're not sure what we're dealing with. It could be anything, this lesion.
Well, I agree with you. Actually, we thought about biopsy, but we are afraid of seeding, and we do not want to ruin his chances of getting a successful surgery.
It is now well accepted that the potential risk of tumor biopsy, such as bleeding and needle track seeding, are infrequent, manageable, and do not affect the course of the disease or the overall survival. In a comprehensive meta-analysis, the risk of tumor seeding after liver biopsy was reported to be in the region of 2.7%, with a median time interval between biopsy and seeding of about 17 months. Therefore, these should not be seen as reason to abstain from diagnostic liver biopsy.
Dr. Ali, can I ask you about a patient of mine, please?
Yeah, sure, of course, go ahead.
Well, actually, I have a very interesting patient. He's a 60-year-old with a stage 4 pancreatic adenocarcinoma with metastasis to the liver. And I've been treating him for the past year or year and a half. And I gave him initially folfirinox, in which he responded well and then progressed. And I gave him gemcitabine Abraxane. And I repeated the imaging, which I have right now in my hand, actually, and it showed some progression in the liver. I wonder if there is something else that I can do for him.
Surely this man has done really, really well. Is he still fit?
Well, the strange thing, his performance is still about 1. His ECOG is 1. He's just having some neuropathy from the oxaliplatin.
In the NCCN guidelines, it is recommended that patients with locally advanced or metastatic pancreatic cancers to have the tumor and somatic gene profiling performed. This would aim to identify mutations that could be targeted with medications. Actionable somatic findings in pancreatic cancers can include fusions such as ALK, NRG1, NTRK, and ROS1, mutations such as BRAF, BRCA1 and 2, HER2 and KRAS, and mismatch repair deficiencies. Pembrolizumab would be an option in patients with mismatch repair deficiency tumor, while larotrectinib or entrectinib are ideal options for patients with NTRK gene fusion positive tumors. Olaparib can be given as a maintenance treatment for patients with BRCA mutated metastatic pancreatic adenocarcinoma whose disease has not progressed on at least 16 weeks of first-line platinum-based chemotherapy.
We also have Mr. Ball, who is a 22-year-old male patient, and he presented to the emergency complaining of shortness of breath, and he was found to be tachycardic. Well, in addition, he had diarrhea, he had vomiting that lasted for about 2 days. We did a CT scan of the chest and abdomen, and we also suspected that he might have a pulmonary embolism. I think we reviewed these images with you, Dr. Ahmed.
Sure. Well, the CT chest ruled out pulmonary embolism. In fact, there was nothing in the chest of abnormality. However, in the abdomen, there was a 12 centimeter lesion involving the anterior segment of the right lobe of the liver. The lesion almost completely replaced the entire segment. It had an irregular and nodular border, low attenuating, and it had multiple septae. It looks suspicious for malignancy. The rest of the liver looks normal.
Thank you, Dr. Ahmed. Actually, also his alpha-fetoprotein was normal. It's about 2.3. What do you think this is, Dr. Ahmed?
Fibrolamellar hepatocellular carcinoma is a malignant liver tumor which is thought to be a variant of conventional HCC. It accounts for a small proportion of HCC and occurs in a distinctly different group of patients, which are young with no underlying liver disease or cirrhosis. Furthermore, the alpha-fetoprotein levels can be normal or near normal in these patients. Histological appearances are the most objective and widely accepted differences between fibrolamellar HCC and conventional HCC. Therefore, histological confirmation is needed to establish the diagnosis. This is particularly important if there is a diagnostic uncertainty from the radiology. As the majority of fibrolamellar HCC patients are young and therefore healthy, major liver resection can be done with low rates of life-threatening complications. Multiple studies demonstrated overall survival of about 26 to 76% at 5 years, with a median survival of 32 to 174 months in resected patients.
We hope you liked our video. This is acting for clinical education.
And don't forget to check the reference down below.
Please like, share and subscribe, and don't forget to join us every Thursday 5 p.m. Greenwich time.